It really is a numbers game. So the first thing we're going to do is describe the POPQ, which is the pelvic organ prolapse quantification staging system. We're going to talk about how the POPQ measurements can direct our surgical management. We'll review the current literature regarding vaginal supported surgical outcomes and provide examples. And if there's time and if it works, and I'm not the most technologically savvy person on earth, we're going to do a little interaction at the end. I have no relevant disclosures. Who knows what this is besides Dr. Giles and me? Has anybody seen this? Okay. So some people think this is a really elaborate way that urogynecologists try to tell people what we do is really super hard. But actually, this is the POPQ. So the POPQ was developed in 1996. The goal of the POPQ was to standardize terminology so that when we're speaking to one another, we're all speaking the same language. It's been tested and has high inter and intra-rater reliability. It's used to enhance academic and clinical communication. Again, this is what it looks like. And this is confusing. Basically, there are 9 measurements of the vaginal walls. So those measurements are taken in centimeters. They're measured, 8 of them at maximum Valsalva, 1 of them at rest. And based on the amount of movement of those walls, we're able to then stage our prolapse. So everything is relative to the hymen. This is kind of the quick and dirty about the POPQ. The hymen is considered number 0, okay? All numbers that go above the hymen or proximal in the vagina are negative numbers. So the further from the hymen, the more negative the number. Things that come distal to the hymen are positive. So again, if the further away they come from the hymen, the higher the number. So the way that I teach our medical students and residents is negative, no prolapse, positive prolapse. It helps to keep that straight. So the numbers that we get have different ranges. And we create this 3x3 table, and it's the same table every time, always when you're talking to colleagues or you're putting this in the chart. So we're going to start decoding this. So the top line is the anterior vaginal wall, the middle is the vulva and the vaginal length, and the bottom line is the posterior vaginal wall. So let's start with the part that's the easiest, that's what's outside, and that's the vulva. There are 2 points, the genital hiatus and the perineal body. So this is a woman in lithotomy. The genital hiatus is the measurement from the mid-urethra to the posterior fourchette of the vagina, again in centimeters at maximum Valsalva. The perineal body is from the posterior fourchette to the mid-anus, again at maximum Valsalva. The vaginal length is the only measurement that's taken at rest. It's denoted TVL, and this is what it looks like. So if the patient's not had a hysterectomy, the measurement's taken to the posterior fornix of the vagina, and the measurement's taken down to the hymen. So in this instance, the total vaginal length would be 9 centimeters. Now the front and back walls get a little trickier, so let's take a little time with them. So using our graph on the left and understanding that our hymen is our point 0, if we're looking just at the anterior vaginal wall, point AA is always fixed. It's always fixed 3 centimeters from the hymen or from the urethral meatus. It's typically the easier thing to see. BA is just the point on the anterior vagina that comes down the most. If it's still higher than point AA, it just equals point AA. And then C is the cervix or the cuff if they've had a hysterectomy. Now, urogynecologists really do like to simplify things because essentially for the posterior wall, we're just mirroring what we just said. So AP is that fixed point 3 centimeters from the hymen. Point BP is the maximum descent of the posterior vaginal wall. So if it's above AP, it's still the same measurement. And then D is the posterior vaginal fornix. So the measurements that we get will then give us the staging system. So like cancer staging, we want to stage what our patients have to discuss the clinical severity of their disorder. Stage 0 means nothing's moving, everything's perfect. The total vaginal length basically stays up where it needs to. Stage 1 is the space that kind of falls in between stage 0 and then 1 centimeter above the hymen. Stage 2 is a centimeter above and below the hymen. Stage 3 is basically stage 1 but further out, and then 4 is maximum descent. So I like to think of it this way. Can make it really easy. Stage 0 means nothing moves. Stage 4 means nothing moves more. It's all the way out. And stage 2 is 1 centimeter above and below the hymen. Those are your 3 easy stages. And if it's a movement above that, it's 1, and below that, it's a 3. Okay, so you can kind of break it down pretty easily. I like this picture because it also shows what we're looking at in another way. So you can see that in this picture, stage 2 is the one that really has the fixed points again, that there's 1 centimeter above and below the hymen. And stage 0 and 4, again, are either no descent or maximum descent. And you can see stage 1 and 3. So just to give another life example, I thought uterine prolapse would be something pretty easy to describe. So this shows the movement of the uterus as it relates to the hymen and the vagina. And I tried to highlight the hymen in each picture with a little blue ring. So we can see on the left, that's showing no prolapse. Then you can see that stage 0 to 4. And then as you see stage 1, 2, 3, and 4 going to the right, you can see how it comes down past the hymen. Now it's all great and good that we can find this on examination, but ultimately the question is, does any of this correlate to any symptoms for the patient? So a study was performed looking at 3 specific symptoms and validated measures for urinary splinting, so the idea that a woman would push up against the anterior vaginal wall to help with urination. Digitation with defecation, so she's pushing on the back wall of the vagina to help have a bowel movement, or a bulge in the vagina. And what was done then was a correlation of those 3 different questions with 3 specific POPQ measurements. So the anterior vagina, urinary splinting, corresponded to that point BA that we talked about. Posterior vagina, BP, was corresponding to the digitation with defecation, and then maximum POPQ value with the bulge. What was found, maybe unsurprisingly, but what was found is that as patients had worse prolapse, the number of patients reporting these symptoms also went up. They went up fairly consistently and went up exponentially with the stage of prolapse. So when we're talking about surgery for prolapse, we're talking about reestablishing normal anatomy. To me, that's one of the greatest parts of my job, is that I can try to reconstruct what a patient used to have. So reestablishing her normal pelvic anatomy. Also, we have to think about bowel and bladder function. It's very common that we have patients coming to us that have myriad pelvic floor complaints. They're having incontinence, or they're having retention, and they're having prolapse, and they're having problems with defecation, pain with intercourse. So we have to really match what their symptoms are and either maintain them if they're normal or restore them if they're not. And then plus or minus sexual function retention. So if patients are sexually active, it's important that we know that prior to us planning our surgery, because we can create problems for patients if they want to retain sexual function and we're being too aggressive with their procedures. Conversely, if they have no interest in surgery, we might not do a reconstructive procedure on them. So another question was asked, does a patient's goal of surgery vary with her prolapse stage? So looking at a group of women presenting to a urogynecology practice, they were asked to report 5 goals that they had with the idea that they would have correction of their prolapse. So patients could report up to 5 goals. The group then combined these 5 goals into 9 separate categories. Well, one might assume that the women would want prolapse symptom resolution, like that would be a very important thing to have if you have prolapse. And that was found. So patients increasingly wanted prolapse symptom resolution as their prolapse worsened. However, more women wanted their urinary symptoms resolved. They wanted their urinary symptoms restored more commonly in all 4 different prolapse stages. It was a more common finding. So as we're thinking about surgery for our patients, there are important considerations that have to be made. The first, is she going to want to maintain her vagina for vaginal penetration? So we have to think about recreation. The second, the route. Do we want to proceed entirely vaginally, or do we want to proceed with a combination of abdominal and vaginal routes? And then the third is, what walls need to get fixed? So we have to determine what's broken and what do we fix. So how do the measurements guide our surgical plan? Well, as every great person knows, if you're trying to restore anatomy, it's really important to know what normal is, right? So it's really important to identify what are the normal dimensions of the vagina. A lot of this work has been done with John Delancey out of the University of Michigan. So women who had normal pelvic organ support underwent MRI evaluation. With that evaluation, they then had mid-sagittal measurements that were taken of their vagina. What was found is that the anterior vaginal wall was approximately 6.5 centimeters long. That was considered normal. The posterior vaginal wall was just under 10 centimeters. So using these as our definition for normal, we're going to be going forward and looking at what happens when it's not. What about clinically relevant prolapse? This was a very important study that was done looking at women who had prolapse findings, and in a standardized interview were asked, do you have a sensation or a lump or a bulge or a dragging sensation in the vagina? They underwent their POP-Q exam, and 80% of these women had 2 or more stage prolapse in any compartment. So what they looked at was the significance of various measurements in terms of identifying patients with symptoms, and this is what was found. If a patient has her BA point that comes down to within 0.5 centimeter of the hymen, she has clinically significant anterior vaginal wall prolapse, so she was more likely to report symptoms. The same was true if she had her posterior vaginal wall coming down to just above the hymen. Interestingly, point C, which if you remember is the cuff or the cervix, had to come to -5. So if the normal vagina is just under 10 centimeters long, this is about halfway down the vagina. So the anterior vaginal wall length and prolapse was also evaluated. These again were measurements taken by MRI in women with and without prolapse. And what was found is that increasing vaginal wall length was positively correlated to anterior vaginal prolapse. And in fact, 77% of anterior wall descent was explained by apical descent of the anterior vaginal wall length. So now looking at, well, if we compared normal women, those without prolapse symptoms, to women with symptoms, what do we see that's different in other measurements? So 30 women with prolapse, who are called cases, were compared to 30 controls. What was also found was that women who had more anterior vaginal wall prolapse also had a wider genital hiatus. So that genital hiatal measurement that we talked about earlier was wider. In fact, it was 57% larger in women with anterior vaginal wall prolapse. Additionally, the vaginal length was 23% longer. So it may be too that our vaginal wall support can get too long and then the support is compromised. What about doing surgery on the anterior vaginal wall? So again, women with prolapse, our cases, were compared to controls. Those same women were evaluated and found that the anterior vaginal length was over 8 centimeters in women with prolapse in 75% of the cases. The anterior vaginal wall length in controls was about that little over 6 centimeters that we talked about earlier. When women had an anterior repair and other prolapse surgery, it was varied, their measurements were retaken post-operatively and they were found to more closely mimic those patients who now were normal. So as part of our prolapse repair, we're probably shortening those women and giving them, again, more normal anatomy. What about other measurements? So we talked a moment ago about how the genital hiatus measurement was enlarged in 75% of women with prolapse. So in another evaluation, patients presented over a 4.5-year span. It was almost 1,600 patients, and measurements were taken at various points. One was the genital hiatus and one was the perineal body. So if we look at the measurements that were taken, so genital hiatus is the GH, and all of these measurements again are in centimeters. Women who have stage 0 to 1 prolapse, which we would, again, based on the previous studies, assume them to be mainly asymptomatic, the genital hiatus is about 2.74 centimeters. At stage 2, which is where most women would become symptomatic, the genital hiatus is 3.6. Stage 3, it's 4.83. So stage 3, the prolapse is protruding through the introitus. And stage 4, interestingly, narrows back to 3.4 centimeters. So overall, the genital hiatus measurement was about 3.6 centimeters. The perineal body measurement was also taken and an inconsistent relationship was observed. So one of the questions was, why does the genital hiatus narrow with a stage 4 prolapse? And the thought would be that as the pressure is alleviated from the prolapse now proceeding as far out as it goes, the hiatus then narrows again because there's less pressure being applied. So as prolapse stage increases, our genital hiatus measurement increases with the exception of stage 4. What about genital hiatus then serving as a prediction for apical support loss? So 450 patients underwent evaluation, and these were 2 separate studies within the same organization, and they were non-overlapping. They only included women with a total vaginal length of more than 7 centimeters because they wanted to include women who may consider being sexually active. The median POPQ stage was 3, and when we look at the graph, we can find that point C also corresponded to an increasing genital hiatus through all the stages of prolapse. So a receiver operator characteristics analysis was performed, and when they did this using 4 different definitions of apical support prolapse, so again that definition of like -5, so halfway down the vagina, 4 different curves were performed. They found a statistically significant point where at the genital hiatus of 3.75 centimeters, patients were more likely to have apical support loss. So think about that number. When we're doing our repairs and think about a wider genital hiatus, you're predicting apical support loss. So if you see a patient with a wider introital measurement, that could be concerning. The other reason this was important, besides the fact that it can predict apical support loss, is that the genital hiatus is probably the easiest measurement to obtain. It's something that we see all the time in lithotomy, so you don't have to really even understand the POPQ well to know how to measure the genital hiatus. And if you see a measurement greater than 3.75, not only can it predict apical support loss, but it corresponds to anterior vaginal wall prolapse. So what's the impact of surgery? So if you can imagine, there is not a lot of information in the literature about the numbers that you can expect with surgery. There are some very key studies. This was a large Turkish study that followed women from early 2011 to mid-2014. Women had at least a 3-month follow-up. What they found was that women who didn't have any surgery within that follow-up time period maintained a vagina about 10, almost 11 centimeters long. But whether you did a laparoscopic hysterectomy, a vaginal hysterectomy, or abdominal hysterectomy, all women had a shortening of their vagina. And it was about anywhere from 8.1 to 8.9 centimeters. What about the effect of vaginal surgery itself? So this was a study that was completed while I was performing my fellowship at Mayo, and we were taking measurements of women preoperatively, immediately intra-op, and then 5 to 8 weeks post-op, and then it was subsequently followed out 6 months and then 18 to 36 months. What was found is that the preoperative vaginal length was measured at about 10.5 centimeters. The immediate length in the operating room when measured when the patient was still intubated and asleep was just under 8 centimeters. There was also recovery of the vaginal length by the immediate follow-up at 5 to 6 weeks post-op that then recovered almost a centimeter of length. So then other people will ask questions. We have a whole variety of approaches as our M&M alluded to. We have patients who undergo laparoscopic surgeries, who undergo robotic surgeries, who undergo vaginal surgeries. So if we look at, does it matter how you perform a uterosacral ligament suspension, either laparoscopically or vaginally? Women were evaluated for uterosacral ligament suspension. They were followed up just over 4 months. What was found was, first of all, they were different patients. Okay, so that's always important to look at with your study. Women who underwent laparoscopic approach had a lower POPQ stage, so they had less prolapse, and they also were less ill. Patients who underwent vaginal surgery had fewer prior hysterectomies. Nonetheless, the surgeries took about the same length of time, although the vaginal approach had more associated vaginal repair, had about the same rate of complications. The vaginal length was a little bit different in them, and the recurrent prolapse rate was about the same. How about robotic versus vaginal uterosacral ligament suspension? A 1-year follow-up, success was defined by these 3 parameters. So prolapse basically stayed above where we know it to be significant. They didn't have prolapse symptoms on their questionnaire, and they didn't need surgery again or use a pessary. And whether a patient underwent robotic or vaginal approach within this 1-year follow-up, they were pretty successful. Robotic surgery was about 92% success, and vaginal was 85%. In terms of comparing vaginal length between vaginal and robotic surgery, women who underwent vaginal hysterectomy with a uterosacral ligament suspension were compared to women who underwent a robotic hysterectomy and sacrocolpopexy. Interestingly, it was a bit of a heterogeneous group in the sacrocolpopexy. Some had a total hyst and some had a supracervical hyst, which does change the measurements. 65% of patients were sexually active. In this group, women who underwent an all-vaginal approach had a slight shortening of their vagina, and women who underwent an abdominal approach had a slight lengthening of their vagina. We can also see that point C was a little bit higher in the robotic group, and the recurrent prolapse was higher in the vaginal group. How about sexual function before and after surgery? So we know that there are women who, when they have surgery for prolapse, are going to want to maintain sexual function. It's important that we know those women before we operate them. If we look at the vaginal length, again, very consistent data showing that the vaginal length before surgery is almost 11 centimeters and after is about 10 centimeters. However, what was really concerning within this study was that the rate of dyspareunia was 19%. So that was 26% of women developed a new onset dyspareunia after they had a posterior repair. In univariate logistic regression, they found that that dyspareunia was associated with posterior colporrhaphy, but it was also associated in women who underwent a posterior repair with a Birch procedure, which is an incontinence procedure that we didn't talk about. So that, of course, is a concern. It needs to be considered in patients as we're planning their surgery. So let's review. Normal vaginal anatomy. Normal anterior length is about 6.5 centimeters and posterior is just under 10. Women are generally asymptomatic from prolapse until it gets to about 0.5 centimeter above and below the hymen, or the vaginal cuff or the cervix gets to about halfway down the vagina. The overall effect of surgery is that it shortens with vaginal surgery, and the vaginal length elongates with abdominal surgery, with the exception of performing a hysterectomy. In terms of surgical planning, the most impactful measurements are total vaginal length, C, and genital hiatus. Genital hiatus of greater than 3.75 centimeters is associated with apical failure, and dyspareunia occurs with 19% of women who undergo posterior repair. So again, getting them maybe narrowed, but not too narrow. Total vaginal length needs to exceed 7 centimeters if a patient plans to become or maintain sexual activity, but greater than 9 centimeters really increases her risk of failure. So there's a little bit of some small wiggle room there. So now what I'd like to do is an interactive audience participation. So if you guys can get out your smartphones if you have one, or if you're like my dad and have a flip phone, you're going to just watch. But if you go to live.voxvote.com and then put in the pin is 41714. So it's live.voxvote.com. And then the pin is 41714. Has everybody got it? Is it working? Okay. I don't know if they do the slides. Yeah. Okay. Is everybody ready, or do you need more time? Is anyone having trouble with the site that they need to get help from Krishnan? Because I won't be able to use this. All right. So this is our first picture. Not sure if everybody can see this well, but this is what a measurement would look like doing a POP-Q on somebody with prolapse. So taking that clinical picture we just had a moment ago. So for the sake of reference, this would be the pubic bone. This is the introitus. Okay, so the measurements, the anterior vagina would be here, and then the posterior vagina would be here, and we have prolapse, okay? So the first question, looking at that 3 by 3 grid, our 9 measurements, what is the area of prolapse? So I'll give you guys a chance to vote. So what's prolapsing? Her anterior vaginal wall, her cervix, her vaginal vault, or the posterior vagina? So you should be able to vote. It should click on the button. Okay, has everybody voted? All right. All right. So let's break down the numbers in terms of what's prolapsing. So our point AA, again, is a fixed point of always -3. That's the highest it will ever get. And if there's no prolapse of the anterior vaginal wall, then BA will also always be -3. So these numbers tell you there's no prolapse of the anterior vaginal wall. So everybody got that right? Awesome. As far as descent, so we know it's not cervix because she doesn't have a cervix. If she did, there'd be a D value here. So C here stands for the vaginal cuff. And the C is -6. So we come here to total vaginal length and we see that the total vaginal length is 8 and it comes down just to -6. So there's really no descent of her vaginal apex. So really what she has is a very large posterior vaginal wall. The vaginal vault really isn't our primary concern because it's still 2 centimeters from the total vaginal length, so that is somebody that doesn't have apical prolapse. Next question. What is her stage of prolapse? Is she stage 0, stage 1, stage 2, stage 3, or stage 4? And again, this is the maximum prolapse of any compartment, so it's always the biggest part of your prolapse that dictates the stage. I will. I'm trying to keep people from cheating. Has everybody voted? Oh, can't yet. Oh, because I just started. You're saying started. Stop talking. Okay, good to know. Okay, can you guys vote now? Okay. How's it going? Everybody sees what they need to? All right. Very good. So, let's talk about this one. So remember that the numbers for stage 0 and stage 4 are the 2 centimeter number. So it has to be more than 2, or it has to be 2 centimeters of the total vaginal length. So in other words, 8 centimeters is our total vaginal length. She'd be stage 0 to 6 and -6 and +6. Her BP is +5, so she actually falls within stage 3. So this patient has a stage 3 rectocele. Does that make sense? Okay. I was hoping this would be a little more fun, but we'll see, I guess. All right, so third question then. So as we're talking about the numbers and we're talking about what do we do for these patients. So we know she has a large rectocele. We know she has a stage 3 rectocele. We know that our anterior and apical support are pretty good. What's the most appropriate surgical technique? So what's the most likely thing to help her? All right, is everybody good? That's exactly right. So a posterior repair would be the most likely thing to help her. She really wouldn't warrant an isolated apical repair because that's not likely to fix her back wall. In addition, if you see her genital hiatus is 4.5, we can narrow that with our posterior pulpoperineorrhaphy, which will actually improve the chances her apex will stay where it's supposed to. So the posterior repair would be the best surgery for her, okay? All right, now we have a new picture. So same bulge. Patient with something coming out of the vagina, okay? So again, for orientation, we've got the pubic bone, we've got the introitus, and then the vagina would be here, okay? The 3x3 table set up exactly the same way. So the first question, sorry. Christian, do you know how to get that up a little bit or no? Okay, is that okay, you guys? There, okay. So we've got our numbers and we've got our picture. So what is the area of prolapse? All right. So we have a split between anterior and anterior vaginal wall. So let's look at the numbers. So first thing that we see is our AA, which is 3 centimeters from the meatus or the hymen. So the maximum support is -3 and maximum descent is +3. So we know she has maximum descent of that point. The maximum descent of the anterior vaginal wall is +6. So her total vaginal length is 6. The maximum length is 6. Okay, so we already know her anterior vaginal wall is out as far as it can go. We have our C point is -2. So there is descent of what we would consider the cuff as well. -3 for our posterior vaginal wall and -2 for point BP, so there's pretty good posterior support. So the correct answer would be anterior vaginal wall and the vaginal vault. Does that make sense to everybody? Okay. All right. So then the next question is, what is the stage of prolapse? So when we're looking at her, again, you're looking at the maximum descent of the prolapse. So whatever compartment is the worst is how they're staged. So would she be stage 0, stage 1, stage 2, stage 3, or stage 4? Is everybody ready? Everyone got this one, right? Yes, she's a stage 4. So she's a stage 4 cystocele or anterior wall prolapse. All right. So then this is our final interactive question. What is the most appropriate surgical technique? Would we do an isolated anterior repair, an isolated apical repair, an isolated posterior repair, or would she get the what's called the blue light special? Is everybody ready? All right. So again, tricky, right? This isn't easy. So in this patient, we know she definitely needs an anterior repair, right? We all can agree to that. We know she needs an anterior repair. She's got horrible anterior vaginal wall prolapse. Would we fix her vaginal cuff? So who in here said, I would fix her vaginal cuff? I would do something apical. Who said that? Okay. So Ross, why would you fix her apex?
Why would I fix her apex?
Yeah, why would you address her apex as part of your surgery? I mean, maybe not you, because you won't be doing any of this in a few short months, but...
Because if you don't address her lost apical support, your anterior repair is unlikely to be successful.
Okay. Who said I would not do an apical support? Who said that I don't think she needs it, she'll be fine? Okay, I don't know you, but go ahead.
Maybe if you just do the anterior repair, it's just pulling on the cuff, so just do an anterior repair.
Okay, so the next thing I would challenge you to think about is, let's say she didn't have anterior vaginal prolapse, and her point C came to -2 from 6. Okay, let's just look at that. What stage prolapse does she have at the apex? So is she stage 0?
No.
Is she stage 1? She is. And what's really tricky about this is that she has a stage 1 apical prolapse, but really remember the clinically significant apical prolapse is if it comes lower than -5, which is halfway down the vagina. So while apical prolapse in this instance seems like it's only a stage 1 and it wouldn't be addressed, she's likely to continue to be symptomatic from her apex even if she just had an anterior vaginal wall repair. And that brings up a really important point. Nobody said that they would just do an isolated posterior repair, and I agree. She doesn't need an isolated posterior repair. But because of her genital hiatus being 4.5, you know you're going to want to narrow that some. Maybe not aggressively, and it also depends on her sexual preferences and her sexual practices. But ultimately, if she says, I need, support, my goal in this is prolapse resolution, I think you'd be remiss to not attend that back wall and give her some narrowing of the introitus. So the correct answer is everyone uniformly agrees she needs an anterior repair, but she will need an apical repair, and then she'll need that back wall repair because of the genital hiatus measurement. Did you guys like this part? Was that helpful? Okay. All right, so there are some questions that still remain in regards to the prolapse. So we've just gone through the fact that there are 9 measurements, right? But we didn't even talk about really some of them. So we know the perineal body measurement doesn't really change anything that we're doing. Does it really matter if a patient's perineal body is 2 centimeters or 6 centimeters? I mean, it doesn't really change anything for her, so we really need to take time getting that measurement. So there has been a proposal for maybe modifying the POP-Q, something like a POP-Q 2.0, so doing some revision of this, and maybe we don't need all 9 measurements. The other thing is apical prolapse staging. So another ongoing debate within our field is, should we really reconsider those raw numbers? If we know that clinically significant apical prolapse occurs at -5, that's halfway down the vagina, should we maybe instead look at total vaginal length that comes down halfway above and halfway below as being more meaningful? And then the third point is accommodation. Size does matter. And I would argue that in our field, despite the fact that the vagina exists for recreational purposes, we do a notably poor job in talking to our patients specifically about sexual practices and need for vaginal penetration and partner size if they're partnered. I think we need to be more deliberate in that conversation, making sure that we are matching what the patient needs and what we're doing surgically. We can go by the numbers, we can go by the law of averages, but again, when you're talking to that patient directly, it's a one-on-one and you have to be very specific. So, the art of reconstructive pelvic surgery is in the details, and there are a lot of them. It's all a numbers game. Thank you very much. This is my other life, by the way.
Great. Who has some questions?
So everyone's going to do POP-Q starting today and be able to communicate to Dr. Giles and Dr. Brown and me without faltering and counsel their patients about the surgical approach. It was that great? Wow. Should get this lecture more often. No questions? Yes.
It's a question about the genital hiatus measurement. Does level 1 support actually support the apex, or is that just like a readout for patients who are at risk of prolapse in general?
So you're asking if about the level 1 support. So you're saying like the Lancey's level 1 support of the apex?
Or the apex is level 3. So like the genital hiatus being wide.
Okay.
Does that suggest that there's a loss of support in the apex, or does it suggest that the patient is just at risk of prolapse?
So it's actually both. So you can use that genital hiatus measurement as a screen to know if there may be some apical prolapse that's there that you should evaluate further. So the study was actually done to ask that question. Can we use an external measurement to predict that somebody has apical support loss right now? And they did. So they thought that GH would make a great screening tool, if you will. But then the other question was, is a lower genital hiatal measurement going to correspond to better success of the apex? And the answer was yes as well. So the idea being, I like the tent analogy. So the force of pressure applied to the ceiling of a tent if the hole is wide does not require as much force as if that hole is narrow. So if there's a smaller space, it requires more force to get those walls to come down.
Thank you for a great talk. I know you've got a lot of research in terms of it's all a numbers game and this is when people are going to be symptomatic, but have there been any studies done in terms of when pelvic floor physical therapy would be helpful, or a pessary, or, you know, I know we can try it for anyone because they're very non-invasive, but are there any studies saying it's really not going to help this patient at a certain numbers game?
Sure. So there was a study that was performed looking at pelvic floor physical therapy in patients with prolapse symptoms. And they did undergo POP-Q staging. And this was patients with all stages of prolapse that when they completed their physical therapy and were performing it as instructed, saw a reduction of their prolapse by 1 full stage in 60% of patients. So that can be beneficial. The other argument, though, is if a patient has prolapse that's a stage 3 or 4 and you're getting hiatal widening, it may be more advantageous to use a pessary to support the prolapse and reduce some of the pressure on the levator muscles so that there can be some contraction of those muscles. So it might be the duality of a pessary and physical therapy may be more advantageous, but the really frustrating thing is that what we're seeing kind of borne out in the surgical literature is that we're not actually seeing a lot of as much prevention with physical therapy as we'd like in terms of the prehabilitation specifically for surgery. So akin to somebody having a knee replacement, having them undergo therapy so that they're stronger and recover better from their knee replacement. We're not seeing the same translation within our literature. But again, having said that, would I ever tell somebody don't do physical therapy? No, not ever. I think it can only help, at the very least, it helps strengthen the core and it gets them in touch with how to actually perform a Kegel maneuver correctly. Because the women who attempt to do a Kegel without coaching, 80% of them do them incorrectly. So if they're actually pushing down and they think they're doing a Kegel, now they're increasing the risk of recurrent prolapse. So that education can be huge.
What do you think you saw the difference between the robotic versus laparoscopic versus the vaginal uterosacral ligament suspension? And does it make any clinically significant difference?
Well, specifically between the laparoscopic and vaginal, the patients weren't the same patients. They were different. So there was some selection bias there. I think the fact that you saw a surgeon predisposing him or herself to a surgical approach, tailoring it to the patient and seeing the same outcome is positive. I think we're doing a good job of saying, I think this patient would do well with this approach. I think robotically what happens when you do a sacrocolpopexy is that there's more contraction of the mesh towards the sacrum during the stage of healing. So there's more scarification. With that shortening of the mesh, it elongates the vagina. And I think that's where you see some of the improvement in the vaginal length as compared to the shortening of the vaginal length with reconstruction. So I would challenge somebody to say if you're dealing with a patient with a shorter vagina, perhaps doing a transvaginal approach may not be in her best interest if she desires to retain coital function. I think there's a lot of variability in the studies. I don't think you can take one set to another set and inherently apply them. I think probably the most important element of this is the ability to counsel a patient that the risk of recurrent prolapse could approach 30% regardless of the route that we're using. But it's not always the area that you fixed. So you might see recurrent prolapse in a different compartment or in a compartment that wasn't as advanced before. I think one of the most interesting findings from the CARE trial, which was the colpopexy and urinary reduction effort study, it was a randomized trial of women undergoing sacrocolpopexy and then with or without a birch to look at improvement in stress incontinence. They've been following their patients out now. At 6.5 years of follow-up, their recurrent prolapse rates are almost 30% based on their definition, which again is definition specific, and the more rigorous the definition, the more likely you are to fail. And that's the other thing, is that definitions are not always standardized. So we've done maybe not the best job in terms of creating an expectation of what should always constitute failure, which is probably some of the variability.
Really excellent talk, thanks so much. I'm thinking about apical support and hysterectomy. And so I'm just curious about your suggestions about maximizing apical support and vaginal length during your vaginal cuff closure. If you have any suggestions regarding that?
Yeah, so I definitely think that historically we were not always as aggressive in supporting the vagina using anything. I think the cuff was just closed. And I think that translated into some of our issues with recurrent prolapse. Getting the uterosacral ligaments during the time of a hysterectomy should be an easy sell because you're right there, you have them, and being able to incorporate them into the vaginal cuff in whatever way someone's comfortable with is important. If you're doing a hysterectomy vaginally, there's probably some attenuation of those ligaments, and that may be a consideration to shorten the ligaments a little bit or to depend on where you're attaching them to the vagina. In a laparoscopic approach, that approach might be taken because of large fibroids or because of no uterine descent. And so in that case, maybe those ligaments are more rigid or whatnot, but I think they'd have to be assessed at the time of laparoscopic surgery. Incorporating them again into cuff closure is important. The other thing that we do vaginally is we do a male McCall caldoplasty or a posterior caldoplasty to close off that space. And I think that could be done laparoscopically to improve outcomes. Even if you bring your uterosacral ligaments together, you could do a Moshkowitz or a Halban caldoplasty, and that would also translate probably into some improved outcomes. That's relatively safe and easy to do. It would maybe take an extra 5 or 10 minutes of surgery, and that's something we can talk more about if anyone's interested in that. I do that with my open cases, so even if I'm doing a sacrocolpopexy, I always make sure that the that there's no other spaces for bowel to come down, everything's closed off.
I have a question.
Yes.
So how important is urinary symptoms when you approach, prolapse? Like the case that you have with anterior wall. Let's say that, she has some urinary symptoms. Do you always put a sling? Do you not? How do patients get comfortable with that?
So when we have patients with specifically large anterior vaginal wall prolapse, we will try to screen them for occult stress incontinence. So we reduce the prolapse, have them cough with the full bladder and see if there's any leaking. We do that standing and also doing that lithotomy. If we screen a patient who doesn't have symptoms, so if she has no urinary complaints and she's positive, that's when we would have an in-depth conversation about the risk that she would have stress incontinence postoperatively. And that is a real concern. I think your question's asking a little bit something different though. Patients can present with urinary urgency and urgent incontinence. They can present with stress incontinence. They can present with both. Sometimes they have incomplete emptying. And if we are unsure about what symptoms she has, we can perform urodynamic testing to help us kind of identify what might need to be managed at the time of surgery. The only kind of urinary issues we can really solve at the time of prolapse surgery is stress incontinence. So what I'll frequently offer to patients, and I think my partners do the same thing, is we can try a pessary for a while too and see if that improves emptying, improves urgency, just to see if that mimics what we do with support. And this actually is a large part of the counseling we provide to patients, because when they have a functional bladder problem, that may not always translate to improvement with an anatomic support. And they have to know that ahead of time. So if they have incomplete emptying with their large cystocele before surgery, they may still have that after surgery. Bladder management is a really key thing of what we take care of in the first few weeks after surgery. I mean, I think Dobie, you'd agree with that. Other concerns, questions, thoughts? I really appreciate everyone's time this morning. Thank you so much.